Good afternoon from Thailand. My presentation today is Biomechanics for class 3 patient without surgery. The patient I'm going to share with you today will be in 3 groups: the deep bite, the open bite, and Ed2Ed class 3. In the first group, the deep bite group, the first one, she has cross bite, and the canine and molar are in class 3. And here is her bite and her face before treatment and after treatment. And the second case, her bite is more severe, is very deep, and the canine and molar are in 1 unit 3. We were able to improve not only her face, but also her bite, as you can see here. And the second group, the open bite patient. This patient presented with 8 millimeter cross bite, and his lower lip is very protruded. And again, we could move his lower teeth back and made his face look more pleasant. I will show you how to do that and do it without surgery. And the next one will be even more difficult with very far away crossbite. She got 10 millimeter crossbite, and we also able to move her teeth back and improve her profile. And the last group, the Ed2Ed patient. This patient has retoconation of the upper and lower front teeth. And we all know that if we procline them, the bite gonna open. How can we fix it? Stay with me and you will know it. And the last one, also Ed2Ed. And in this case, the case got more difficult since her canine is very high. During leveling, the bite gonna open. So I will show you how we can close her bite and get her in nice occlusion. Let's start with the first group, the deep bite. This is her face. She has crossbite and deep bite. Her face looks fine for me. And this is her bite, anterior cross bite. Canine and molar are all 3. And her upper front teeth are flat. So we need to move her front teeth forward to shape her arch form. And after tracing, I draw the occlusal plane, and you can see that the upper front teeth related to the upper lip is in good level. So I will move the upper front teeth like a 2 millimeter forward to correct that flat arch form. And I will move the lower front teeth back to correct the crossbite and also improve her lower lip. And the mechanic I use will be round wide to move the upper incisor forward. For the lower, we need to move it down and back. So the mechanic that appropriate for this kind of movement is step down in rectangular wire. And the lower teeth, we got so many spaces. So it will help me for retracted the lower incisor. So at the start of the treatment, we put 0.129 tie with bend to maintain his upper front teeth. We don't want the upper front teeth to move forward. Otherwise, it will hit the lower front teeth. And we will move the lower front teeth down. Then later on, we will move the upper front teeth levelly. For the lower incisor, as I already mentioned, we will use rectangular wire with step down. So we use 1622 TMA. with L loop and step down the upper front teeth. How can it happen? From this picture, after we move the front of the archway up toward the slot of the blanket, you can see that the shape of the Y and the slot of the blanket will produce the moment of couple to tip the front teeth back, and the moment of force will bring it down. So step down in rectangular way is the most appropriate biomechanics for this case. After we move the lower front teeth down enough into edge-to-edge level, so now we start to retract the front teeth. Use power chain to pull the lower front teeth back. We keep doing that until we get nice overjet and overbite. Later on, we will do the re-leveling and finishing. And this is a picture after we take the braces out. This is how her face looked after finishing, comparing before and after treatment. I will move the tracing at the initial of the head frame to the final head frame. So you will notice that the upper front teeth, we would able to move it laterally as we planned. And also the lower front teeth, we move it down and back as we planned. So this confirms that if we apply appropriate mechanics, we can achieve the tooth position as we would like it to be. And the lower lips move back as we expected. And this is the second one. This is her face. Her face doesn't look that much class 3. And her smile look nice for me. However, when she bite down, the bite is very deep. The canine and molar are very, very thin. And her shape look even more class 3 than her face. And after I do the tracing, the plan for her teeth is to move the upper front teeth forward, to push her upper lip forward, since her upper lip is kind of fat. And of course, the lower teeth have to go down, and the mandible have to rotate backward to reduce the chin prominence. In order to do that, the upper molar and lower molar have to be extruded to open the bite. The mechanic that good for this patient is to use distal L loop to push the front teeth forward and at the same time extrude the posterior teeth. For the lower jaw, we don't need any protection. So just only plain archway, and we do the step down on the lower incisor and lower canine as shown in this picture. Then you can achieve as we plan in the tracing. And this is a picture of the front and the lateral view of the loop that I went for this patient. And this is a sequence of how I protect the front teeth and extrude the posterior teeth at the same time. After we get nice overjet and overbite for this patient, we have to prevent the upper front teeth to move back during moving the posterior teeth forward. We put stop on the distal of the canine and in front of the molar and move the premolar and molar to finish the case. And this is how I move them. We move the premolar and then second premolar, and then we take the stop in front of the molar out and move the molar forward. And this is how the bite look after we take the braces off. This is her face. Compare between initial and final. Initial, final. Compare her face and her bite before and after treatment. And again, I will move the tracing from the initial to the final. And you can see we can move the front teeth forward, and also we can rotate the mandible back, and of course the molar on lower and upper got extruded. And the next group is the open bite group. This is the first one. This is his face. He got long face and incompetent lips and a little asymmetric face. He got low smile line, and he got convex profile and protruded lower lips. When he smiled, you can notice that the upper incisor retruded and the lower incisor protruded. So our plan is to move the upper front teeth forward and move his lower teeth back. In the model, the mouth occlusion even more severe than in the picture. It's allowed 8 to 14 millimeter class 3. From our plan, all the information we got, we need to extract to lower 4. And this is how his bite look at the beginning. We start with 0, 1, 2, 9 tie, and we bend the Y up on the lower. We don't want the lower incisor to come forward. So we put curve of speed on the lower to prevent the lower incisor move laterally. We move on to the 16 9 tie and still maintain the curve of speed. As well as in 16 22 9 tie, 16 not 16 22 9 tie, we still maintain the step up. And when we do the rectangular Y, we use the 1622 TMA with distal L loop. Now it is a time to move the lower incisor and canine down. Because when we do the leveling in rectangular Y as the previous case, the lower incisor won't come forward. We keep moving the lower incisor and canine down by reducing the step, and later we will do the step down. For the upper, we also use the distal L loop to protect the upper front teeth. And we also be able to use this loop to shift the midline, because on the right, the space close too fast compared to the left. So we activate the loop on the left to shift the midline. And in this visit is almost there. And in this visit, we can get almost nice overjet and overbite. We achieve the overjet overbite by anterior cross elastic. And this is by most recent occlusion of the patient. The patient cannot finish because still have some space on the upper, and we also help the patient for the impacted teeth. He got horizontal impaction on both lower molar. One side already corrected and the other is ongoing for correction. And this is bite and the most recent occlusion. And his face before and on progress. You can see that his profile got improved a lot since his lower lip got retracted. And this is his smile on the profile. From the shape, you can see this is our plan, and this is what happened in the patient. We are able to move the front teeth forward and also move the lower incisor back to improve his profile. And this is the second one on the open bite group. She presented very crossbite with 10 millimeter negative overjet, and she got spacing everywhere in the lower. And this is her tracing. We have to move her front teeth forward to correct her nasolabial angle, and also have to tip her lower teeth back to improve her profile. For this kind of movement, I will use the vertical loop for protecting the upper incisor, and the lower one will use simple tipping in the round wire. So this is the process building leveling. And after the lower teeth got aligned, we start to retract in the small night time using power chain. After we group the lower teeth, we start to move the premolar and then the second premolar. And finally, we decided to close our space for her. We don't want to leave the space for implant, but because the patient requested for no dental prosthesis. So when we finish this patient, you can see that one side of the canine on the right is in class 3, whereas in the left is in class 2, but we can close our space for her. The space still left in the upper because the patient kind of burned out and she would like to take her braces out. And this is the picture of her teeth before and after treatment, initial and final for the upper and lower, and her face initial and final, her profile initial and final, and her panel. You can see all the root is in good alignment. And they still in the bone, even we tip a lot of the low incisor lingually. And this is superimposition. And again, I move the tracing from the initial to the final. And you can see we move the upper front teeth laterally and move the lower incisor lingually. Let's move on to the last group, the Ed2 occlusion. This is the first one. This is a bite. First, when we look at the patient face, we have to make decision whether this is surgery or non-surgery. If you decided to do the surgery, you have to tell where to improve the face. And extraction or non-extraction. Extraction may cause ditch in this patient. So we make a decision for non-surgery and non-extraction. Since her teeth is kind of upright, so we have to move her teeth anteriorly to improve the inclination. And the difficult one is the molar is also lean medially. We have to upright them as well. So we put 0, 1, 2 night tie with bend in this patient, and we're gonna reduce the bend little by little to prevent the side effect from the high canine. And the technique was published in Angle Orthodontist and also Orthodontic Web. You can look at this paper in this journal. This is digital ed research. We continue to reduce the bend we place in the wire. And after we get overjet and overbite, we do the braces on the lower. And 4 months later, the alignment got improved. 3 months later, it looked better. However, the upper incisor look very, very procline. So we have to do something to correct the proclination. So we use the round TMA with step down to bring the upper front teeth down. So it causes retroclination on the front teeth. You can see we put step down on the upper incisor. However, it's not enough for correct that proclination. So we put rectangular Y. Then we do the step up to cause the retroclination for the upper incisor. You can see the inclination got improved after we put step up on the upper incisor. We still need more retroclination. Since her incisor shape is not nice, so we can do the interproximal reduction for shaping the upper incisor and reduce that proclination. And this is the finishing before and after treatment. And this is the inclination and the alignment that we correct for the patient. Her face before and after treatment. This is the upper inclination that we correct. First, we correct the crowding. However, the crowding caused the proclination. And then we use the round Y, we step down to correct the proclination. We use rectangular Y to correct again, bring it up, and the inclination got improved. And finally, we do the proximal reduction and close the space. The round Y, if we move it up, you see, we bring it down, the teeth will be more retrocline. This is how we correct the proclination. And the next one, we use the step up in the rectangular Y. And this is the moment that causes the lingual tipping for the upper incisor. And this is the last case. The difference between the first and the second case is the inclination and also the canine position of this case. The second one have the high canine. If we put the Y in the canine, it will bring the upper incisor forward and open the bite. The first one have upright incisor, but the second one have very proclined incisor. So after leveling, we found that the upper front, the front teeth has open bite. So we have to close the bite. We use 0.14 stainless steel. We step down on the top and step up in the lower. We can close the bite. However, we got open bite on the posterior teeth. We use vertical elastic on the canine and premolar to close the bite. And then we use 0.129 time piggyback on that utility Y to suck down the occlusion. And this is how the bite looks after we close all the posterior open bite. And here we come to the state of the finishing. And this is a picture after we take the braces out. The picture of her face before and after treatment. And this is how her bite changed. After leveling the bite open, we close it with the round Y, with the step down to close the bite. And then we use vertical elastic to close the posterior open bite. And then finish the case. This is how the bite looked before and after treatment. So in conclusion, we have to look at the patient face and decide whether this is extraction or non-extraction, where we're going to improve the patient profile. Then do the tracing and plan for the upper tooth where it should be to correct the bite and correct the face, and decided what kind of mechanic we're going to use, and then treat the patient, change the teeth into a good occlusion, as well as improve the patient face. Thank you very much for your kind attention.